I mean, the fact of the matter is that iron deficiency in women is rampant. I can tell you I don't know anything about you, and I'm not going to ask you any personal questions, but I can tell you right now, if I were to do a bone marrow on either of you right this second, there's a 60% chance it would have no stainable iron. And if either of you have a child, move that number to about 85. Okay, so that's fact. And it's a long-standing issue, so it's really time that we address it. Preconceptual iron sufficiency is something that is absolutely essential. And iron deficiency at any week of gestation, or at least anemia, has been associated with a statistically significant increment in spectrum disorders in the baby. So let's take a pregnant woman who walks in. If I'm getting off topic, just redirect me. A pregnant woman walks into her OB and goes, "Hi, I'm pregnant." A fair number of tests are ordered, and they should be. They check for syphilis, gonorrhea, AIDS, hepatitis, measles, rubella, liver functions, and they do a CBC. But if you're not anemic, they don't check an iron study. They don't even get a ferritin, or if you're non-anemic. So the United States Preventative Services Task Force says there's insufficient evidence to recommend routine screening for iron deficiency in the absence of anemia. That's so outrageous it borders on negligent. The prospective studies, one of which I had the privilege to do, shows that 50% of you, 50% of women presenting gravidas in the first trimester are iron deficient based on serum ferritin, percent transferrin saturation, or both. When you get further into pregnancy, that number goes much higher. 25% are severe, 40% are never diagnosed. It's outrageous that we don't do a ferritin at diagnosis. So in pregnant women, non-anemic iron deficiency is present in half. That means 50% of you are ignored. Ignored. That's the right word. I think we're going to fix that. FIGO just published an entire supplement, and I had the privilege of writing one of the sections, which is really the management of pregnant and non-gravid iron deficiency, and where we talked about the importance of preconception iron repletion, intrapartum iron repletion, and stressing that it's much more important to deal with intrapartum iron sufficiency rather than postpartum iron repletion. Babies born iron deficient have measurable decrements in behavior, cognition, motor function, and brain development. To give you an idea how outrageous this truly is, we don't check babies for iron deficiency at birth. We have their cord blood. We have it. It's in our hands. All we can do is check off a ferritin, but we don't. But what we do is we prick the heel to look for phenylketonuria. I'm not saying we shouldn't do that. We absolutely should. It occurs in 1 in 25,000 babies. And if you miss it, you get a neurologic vegetable. But iron deficiency occurs at a level associated with measurable developmental decrements in 1 in 4.
How do you choose between oral treatment versus IV treatment?
All right, well, now we have to define who I am. I'm extremely polemic. I think oral iron is ridiculous. Okay, ferrous sulfate's fine, ferrous fumarate's fine, but if you have inflammatory bowel disease, heavy uterine bleeding, chronic kidney disease, collagen vascular disease after bariatric surgery, or pregnancy, where oral iron doesn't get to the baby, doesn't get to the baby, the data's there. And now, if you would have done this interview 2 months ago, I would have said the big problem I have is that we don't have proof that IV iron does. Now we do. It was just published In the American Journal of Obstetrics and Gynecology, MFM, Awomolo, Awomoll, is the first author. The senior author, I believe, is Megan Hill. And IV and not oral iron corrected the baby's ferritins. Now, what we don't know is that going to make a difference in development. But our anemia study, which is called Rapid Iron in India, over 4,300 women accrued, finished. We'll have the last delivery of those 4,300 women in about 8 weeks. And we should have our first set of data in February. The second phase of the study is called Rapid Iron Kids. About 1,000 babies, all of whom had ferritins. They're going to get MRIs to look for brain geography. And we really believe we're going to show a difference in development in the babies who got IV compared to oral iron. I hope.
That would be amazing. What a game changer for the world.
Yeah, this is a game changer. I mean, it's time. I was just in Switzerland last week. I was invited by the World Health Organization to talk about setting up a platform for the administration of IV iron to pregnant women in lower and middle income countries. But I'm telling you, I don't know that I'm going to live long enough to get the World Health Organization to move their behind.
Hopefully. That's all very inspiring. So basically, pregnant women should not receive oral iron.
Not after the first trimester. Now, in the first trimester, that's the only iron I prescribe. Not because IV iron is dangerous in the first trimester, but because there's no safety data with IV iron in the first trimester. I've treated 9,000 pregnant women, and I have 0 serious adverse events and 0 negative baby outcomes. And if either of you think that there's a significant difference between 0 and 1, we have a philosophical difference. 0 is the number that I need to live with. And so I'm not going to mess around with trimester number 1. I tell them to take 1 iron pill every other day till 14 weeks. And then I give IV iron. And if they said, if you can't tolerate it, just don't take it, eat iron-rich foods, and I'll give you IV iron at week 14.